take the red pill, you stay in Wonderland. And I show you how deep the rabbit hole goes.
Welcome to Life in Red.
Okay, first off, Doctor, let me just start by... Your podcast is amazing.
Oh, my God. I would blush if I could, but I can't. But you're one to speak. First of all, that intro music is straight up gangster.
Do you like that?
Oh, man. You saw me. I was just jiving to that beat right there. And, no, that's gangster. You have a fantastic show, and it is truly a privilege to be on.
Thank you very much. So, Kwadwo Kyeremanteng.
Yes.
Nailed it. Doctor of Palliative and Critical Care.
Wow. Yes.
Did my research, did my homework.
Yes. So
yeah, no, it's amazing. As I was saying just off mic, I was on my run before the show, and I was taking a listen to your latest episode with Andre Picard, and I honestly, and this is not to like boost your ego, which I'm sure it's going to do anyway, but like it's one of those podcasts where it's kind of like everyone should listen because it's going to resonate somehow, and it's like important shit to know. You know what I mean?
Oh, thank you
very
much.
That's why I just want like an ovation for it to start.
That really, and me, honestly, especially from a fellow podcaster, it means a lot because that has always been the goal, that your grandma could listen to the show and take something out of it. So
yeah,
that means a lot, Ryan. So
yeah,
thank you very much.
You're very welcome. Speaking of the podcast, it's solving healthcare. I guess your aim is you're trying to, in your own way, find out ways to solve and make healthcare better.
Absolutely.
Can I sum that up?
Yeah, and it came from, our research group, we were doing a lot of projects and successful at producing these publications. And 3 years into it, we hadn't really created any change whatsoever. And so the whole research was looking at ways to make healthcare more sustainable and reduce spending. I remember sitting down and be like, what has changed, guys, despite us doing these projects? And so I've always been a podcast enthusiast, and I said to myself, like, why don't we just try this? It was committee year. This was probably supposed to be a 2021 plan, but I kind of got impatient, just started going, and and I thought maybe this is a great way of increasing awareness where some of our common healthcare problems are displayed, and ideally, come up with solutions, start up the dialogue, and also like scale up some of the awesome initiatives people are doing. Because I gotta tell you, I'm in healthcare, and I'm learning about some of the most beautiful initiatives. Like one of the shows we did was with Jeff Turnbull, who works in inner city health, and he sees vulnerable patient populations, and they see so much volume that they say they estimate that they see about 3,400 emerge equivalent visits a year. So that's 3,400 patients that are not going into emerged, increasing wait times and so forth, but they're handling right there at their clinic with great care in an environment that works well with them. And this is something that people could do throughout the country. Like it's not a very Ottawa unique scenario. So like these are kind of examples of initiatives that people are doing that, people might not be knowing about, and hopefully it inspires people to act and make healthcare better.
That's one of the things, I love about podcasts, and the thing I've even found doing it, and doing the research on finding guests, and there are a lot of people doing incredible things, and just because they're not getting notoriety from major media or newspapers, it doesn't make what they're doing any less. And you can tell it's great because they're doing it out of just the goodness of their heart or from a passion, rather than like, look how great I am.
Yes.
You know what I mean?
Genuine.
Yeah.
Yeah.
So like the things I loved listening to your podcast, one, like, it was accessible. So I know a little bit, but most of my knowledge is from House and Grey's Anatomy.
Yes.
So
can I just say too, there's not as much nookie that happens in the hospital, and if it does happen, I'm not aware of it. You know what I'm saying? But yeah,
I remember. Yeah, my mom's a nurse, and my friend Casey, who's been on the podcast before.
Oh, I heard that episode.
Yeah, and she's a nurse, and it's always is it really like y'all just sleeping with each other all the time? So it's good and sad to hear, I guess you could say. But, that to say, like, I don't know a lot, but maybe I know a little bit more than the average person, per se. But I could follow along with your you weren't using, like, these big lingo medical terms that I'm like, whoa, like, couldn't follow along. It was inclusive. You were talking about transgender health, vulnerable populations, like you said, indigenous. You were talking about things, again, that you don't hear a lot of because, one, maybe they're not as sexy or it's not the coronavirus. So, there's no mass panic. What kind of led you down that road as well to cover things that, maybe you're not putting an episode out of all about the coronavirus. You're just because that's a recent example as we talk here now.
Yeah.
But you're talking about things that maybe some people neglect to talk about.
Yeah, that's fair, Ryan. It's just, I think what drives that personally is, a lot of us got into medicine to help and to help those that are in most need, and those populations are often the ones that need the most help. And it really, like, I got to tell you, there was a few months back, we treated a lady who was IV drug user. She was younger than I am, a mother, and she died from her complications of her IV drug use. And you ask yourself, if something happened earlier, would she have to be here? Would her 10-year-old daughter have to say goodbye? And when you see things like that, you can't help to not want to bring awareness to these issues and try to actually put resources into trying to help these patient groups. And it's just, this is what we're meant to do. We're supposed to be helping those that are most in need. And I could speak personally, like, from a guy that, like, we all could say we're busy, right? And I got 3 kids. Shout out to Teddy, Marlo, and Zeke. What's up? And you spend and during medical training, you spend a lot of time being all about you, like trying to get that knowledge base, trying to get that, to try and be a good doctor. It takes a lot out of you, but at the same time, you are so self-absorbed. There's no helping others. Like, there is helping others in the day-to-day, but it's not outside of medicine. And I think, after you get a few years out of your career, you could say to yourself, what more can I be doing? And, I think this is part of that. And a lot of colleagues that have now, I find, that are further out of their career, like further out of their training, you're seeing more starting some charitable organizations, being involved more in the community, and I think that's kind of part of it too. I don't know how I got here, but yeah, it's important to help out there.
Yeah, absolutely. So for context, a palliative doctor is what?
Yes.
For those that don't know.
Okay, so palliative care is, we basically see patients that are closer to the end stage of life, and we really look at issues around that. So making sure that their symptoms are controlled. So whether that's pain, whether that's anxiety, whether that's, shortness of breath, nausea, all these things we try and really contribute, like help out to manage these symptoms. We're also, try and communicate expectations during end of life, what to expect, what the trajectory might be. But ultimately, it's, helping managing pain and symptoms during the dying process.
So your whole job is to take care of, not to say your whole job, but you're responsible for taking care of people who are dying.
Yeah, that'd be the short version.
Yeah. What kind of impact does that have on you? Because we had Michael Dixon on, who he's a funeral director, among other things. But as a funeral director, you're around people in the saddest part of their lives. You're around death,
Mm-hmm.
right? You're watching people, die.
Mm-hmm.
How does that impact you mentally, physically, emotionally? How does
that's a good
how
question.
do you handle
Ryan.
that?
Yeah, I get that question a lot.
Yeah.
They're like, how can you do something that's so depressing? And one thing that's absolutely clear to me is this is one of the most special times to be in people's lives, and to be part of it often is a true privilege. Because, I had no control of what's going on. If they got their stage 4 lung cancer, they're dying regardless if I'm there or not. But to be part of making it less painful or making it as peaceful as possible, bringing closure to the family, honestly, out of all the stuff I do, I feel like it's the thing that has the most impact, because taking some of that pain away can have a lifelong impact for the kids involved or the spouse. And so I have a lot of satisfaction or from my job from that sense. But there's always a couple cases a year where it's just too close to home.
Right.
Like I won't, just for confidentiality, I gotta keep it vague. But there was a young patient that had a very aggressive cancer, and one of the cancers that you have no risk factors. It just came out of the blue, and his wife was pregnant, and the whole goal was to just make it to see the birth of his daughter. Okay. And I got to tell you, when he was extremely debilitated, I might get teary-eyed by saying this story, because it was a lot. It was a lot.
Yeah.
Wheeling him into that room and seeing his daughter, who, he couldn't hold, and he couldn't effectively hold, and knowing that he's got days or weeks to live and not going to be part of that wonderful child's life, would just that stuff is hard.
Yeah.
As a guy that has, relatively similar age, a young family, you feel that. And, those cases, luckily they're not as common as, elderly people passing, and but those can be tough. And what we try to do is be there for each other, amongst our colleagues.
Right.
We'll, sit down and talk about why this is tough. I'm a guy that plays likes to be physical as an outlet. So I do a lot of hockey. I go to the gym. Those are important parts of my what's the term, decompressing, or whatever the term might be. And then laughter. Those that know me well know I'm a bit of a jokester.
Yeah.
And having that release is an important part of life. To be able to, smile, and those are mostly the way I cope. But all my colleagues will tell you, they're grateful for the work they do, but it's always a couple cases a year that it's just a little too close to home.
Yeah.
And that's when you hug your colleagues, you call a friend. And
Yeah, I mean, I remember I was in high school, but a child who was very, very close to me died of cancer when he was young. And I remember going through the wake line and they had an open casket. And when I saw the child, I couldn't take it. So that was one of my very first experiences as a more of a, I would say, adult mind of being close to death in a way. Mm-hmm. So I always, and that's why I think people ask that, how can you go through that process almost day in and day out? And, mm-hmm. But I like the answer that, it's not really about you. You're taking these people through this emotional, but special time in their life.
Yeah. And Ryan, sometimes there are times too where, you're part of, you're really part of the healing. One of my favorite moments in general when it comes to death and dying is you'll be 10 people sitting in a room, and dad's dying and on his deathbed, and we talk about some of the silly jokes he used to do and funny outfits he used to wear during Christmas parties, and there's laughter in the room. There's sharing, and it's beautiful. It really is. And my palliative care colleagues, especially the nurses, shout out to the TOH nurses, those also in Montfort Hospital, they help create that. They really, you'll hear about, sometimes you'll see families that are not wanting to come or don't want to be around one of the siblings or whatever. And, I can think of a number of nurses that get on the phone and let them know, it's important for you to be here. You really don't want to, for lack of a better word, screw this up for yourself and your family. It's time to be present,
right.
And I can't count how many times families will say, thank you for just laying it out. Thank you for being honest with us and allowing this process, which is already super tough, losing a loved one, to make it a little less or significantly less painful than it has to be.
Is there something you've learned through this process of now being the doctor from before about death and dying? Is it more comfortable for you now? Do you have maybe more increased anxiety about it? Yeah. For a little context, the reason that I first started getting panic attacks when I was a kid, the introduction, I guess, to my anxiety and mental illness was thinking of my own mortality, and that one day, no matter what, I have to die, and that would send me into a panic attack. Mm-hmm. Now being close to it, seeing people go through it, are there things you've learned? Are there, is it as maybe scary as we think? Is there, you've talked to people who know they're dying and can have those conversations. Are there things you picked up along this way about it?
Yeah, I like that question, Ryan. The things that I've picked up along the way is most people, there's a few things. One, people know when they're approaching the end. There's this spooky phenomenon that happens where, I will look at a patient or their vitals, I'll assess them, outside the realm of palliative care even, but I'll assess them and they'll look me in the eye and say I'm going to die tonight or I'm going to die soon. And you're like, look, listen, Mrs. Nelson, your vitals are okay, everything looks good or whatever. And the next day she will pass. It is weird. People have a feeling, a premonition. I don't know what it is.
So there's no scientific, chemicals in your brain being released or anything like that?
Maybe there is, but it's nothing that we're picking up on.
Right.
And I can promise you most docs and nurses have experienced this at some point, and it's weird. I don't know why that happens. That's one thing I've learned. In terms of myself, I was... I would say I'm less fearful than I was when I first started. I think when you see someone pass and you realize often how peaceful it could be, especially if, if we know it's happening and we're anticipating it's happening, a lot of people's fears come in terms of the dying process. Like, am I going to suffer? And, you know, most of the time, I would say that doesn't happen, you know, especially when it's a planned death in terms of we know what's happening. There's good palliative care involved. That's another thing that I think has made me more comfortable with the dying process. There's so many things. There's these other unique phenomenon where, say grandma's dying, and she has a daughter that's coming in from Australia, and it looks like she could die any minute, whatever. Some patients, they're not even conscious. They'll hang on till that daughter from Australia makes it, and then minutes or hours later, they pass. Or there'll be the opposite scenario where there's 40 people in the room, always, and mom's never alone. The second everyone goes out to get a coffee, then she passes. Like, there's these kind of like unique circumstances around the dying process that it's almost like they're speaking to us despite being unconscious, and they understand what's going on. That's another kind of unique thing I've picked up on. I'm trying to think, there's so many.
We got time.
Yeah,
the rest of the podcast.
Yeah, let me think.
But you know, it's while you're thinking, it's interesting that, like, you know, you always get those lists on Facebook. You know, 10 lessons from people on their deathbed.
Yes,
you know what I mean? Like, I think those people really resonate with a lot of people, because you're always, I mean, that's the end, and people are always like, okay, like, I don't want to regret life, and I don't want to like miss out on anything. I want to make sure that when I'm there, I follow all the rules that these people before me have told me about, so that, like, I've lived my life with purpose.
Yeah, and I mean a lot of those, you know, Facebook lists, I got to tell you, are true.
Yeah,
like you're not gonna regret work. You're not gonna, want to work more. There's no one on their deathbed that says, like, I wish I would have worked extra hours on XYZ. I wish I would have spent more time with family. Like, those are common links. There's like closure with family. Like, when, you know, there's been what's the word, when the relationship's been difficult with a son or a daughter. Like, that eats at a lot of patients near the end of life. Like, they really want to reconnect with
make amends,
and also the people that are being left behind. Like, they also, that's a part, a really important part of the grieving process. So these things you definitely do. They definitely do come up. I can't think of all the things on the list, on a common list, but, you know, those are some of the themes that come to mind when patients are passing, for sure.
Right. It's interesting, eh? Like, to think of.
But you know, Ryan, though, like, the other thing that's kind of, you know, the advantage of working in this field, or if for lack of a better word, is you truly do realize how fragile life is. Like, you really do. Like, you know, Kobe Bryant died a couple of days ago.
Yeah.
Like, that's crazy. And his daughter.
Yeah.
Like, that's crazy. And the stuff that we see, like you know, in the palliative care or in my ICU job, where someone is like, I'll think of those that my fellow civic crew, when we lost one of our nurses and her husband got into a fatal car accident in April 2018, and all of a sudden, you know, 2 kids are now orphaned, and, you know, healthy. It's 11 o'clock, going out for dinner or whatever, and then life is gone just like that. So, like, you'll notice a lot of people in my field, they don't have that that expression, I will, you know, travel when I'm retired. I'll do all these things after I retire. No, man, you gotta live now. Like, if you could afford it and it's within your means, there is like, do it now. And I can't count how many times, and the nurses out here will they're going to be nodding their heads when I'm saying this, but the medical professionals that retire at, they've been talking about retirement forever. Their 65th year, they retire, and then 6 months later get diagnosed with breast cancer or some fatal illness. I can't count how many times that has happened.
Oh my God.
It's crazy. So, I mean, not to be too paternalistic and stuff, but you do live now.
Doctors are YOLO for sure,
Yeah,
eh?
for real.
You only live once.
Yeah. I mean, I would say not all doctors or medical professionals have that same mindset because, they don't, a lot of my colleagues aren't seeing death and dying on the regular.
Right.
You know what I mean?
Right.
But those that do, like, I think that's an important part of their mindset.
So I'm just picking up on the thing. So I missed the part of the ICU. So you also work in a intensive, what is that?
Intensive care unit. So,
okay.
Actually, your nurse friend,
she's at the Civic, but she works in vascular surgery, I think.
Oh, yeah, A2 or...
Yeah.
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 What was her name again?
Casey.
Yeah.
Shout out to Casey.
Shout out to Casey.
She's going to be listening to this.
What's up? Come see us in the ICU. So my other job was my main job actually is in the intensive care unit. So basically any patient that needs to be on life support of some sort comes to the intensive care unit. So if you've had a crazy car accident leaving you brain, like having a traumatic brain injury, where you need to be put on a ventilator, that's us. If you got a really bad pneumonia where you need to be put on a ventilator, that's us. Really bad bleed into your brain, that's us. So basically anybody that needs support to manage their airway, breathing, or circulation comes into the intensive care unit. So the sickest of the sick, that's my gig.
Right. So as we talk about the coronavirus, if that were to spread,
yes, like
they potentially could be coming into your unit.
Like we are already talking about, how we're gonna have to approach this, because I was not here for SARS and I was here for H1N1, and which, I mean, I don't want to talk out of my butt here, but in terms of like how, the prevalence of it, but the thing that was scary about H1N1 was people that were healthy could die. You know what I mean? Like a lot of these aggressive bugs, they mostly the patients that are most vulnerable, like the elderly or the people that don't have normal immune systems. Right. Those are the ones that really truly need to be scared. But occasionally we get these bugs that you and I get, and you end up in the intensive care unit. Like I could think of, there was a Ottawa professor that died about 10 years ago from the H1N1, and so what I'm trying to get at, that it's scary in that way. But we also plan for the increased number of sick people. Right. So normally, for example, your intensive care unit has about 24 patients. Easily, you could start going up by, 25%. Right. Because it's already started to snowball, at least the coronavirus in China, where you see the numbers every day kind of like 25% up. It goes from, it was like, I think it was 2,000, it was 4,000, and I think it was like 8,000 something confirmed cases this morning. You had one pop up in BC. I think there was one being screened in Ottawa. I don't know where that was, and by the time this gets released, it's gonna, go much, sure. But I just try to, and you'd be able to offer a good opinion on this. When I see stuff like this, of course, it's important to be cautious and take all the precautions like you would with the regular flu. Wash your hands, cover your mouth when you cough, or with a Kleenex. I think a lot of hysteria gets made over it, which doesn't really. You get like every news hit is like dun dun, your update, confirmed case, and you're like, holy shit, what's happening? Oh my god! Like it just, I believe it gets blown out of proportion a lot. Yeah, and when I say this is just an opinion, not an expert opinion. Okay, right. I'm along the same lines as you. Like I think we sensationalize this a bit. It is once again, it's scary because, you know, people that are healthy could be affected and could be more severe than other bugs. But from my reading and my understanding, the people that you hear about that are passing mostly are patients that are, you know, not young, that have other medical problems. And so, you know, I personally, you know, I don't try and spend time worrying about it because I don't know what I'm going to do about it, except for everything that as you mentioned, wash my hands, you know, you know, if I'm feeling ill, not being around other people that are ill, like just taking care of myself. But when I'm in a position where I don't think I could really do anything different, I don't, like my bias, I don't read the news. Like, I'm not looking at updates on coronavirus. Yeah. For sure. If it's going to be something that I need to know, I'm going to find out.
Yeah. Yeah. That's a good way to put it, right?
You know what I mean?
By the time this comes out, who knows? It could be the next pandemic. It could be gone.
Yeah.
That's the funny thing about these things. It kind of just, you know, even, I mean, and not to, I guess, kind of dampen the severity, you know, like every lost life, of course, is unfortunate, you know, but when you think of things like Ebola or the Zika virus, H1N1, SARS, like if we're talking about pandemic and like all these people are super worried about it, like the odds are like, it was like, I think SARS was like 880 deaths, which is awful. Mm-hmm. But when you think that regular influenza killed more people than that, that year, probably, like you got to look at things in perspective to everything.
Yeah. And I think I've come across an article or two saying exactly that. Like, at this point, influenza has been more deadly than coronavirus. So, you know, get your motherfucking flu shot. You know, like, take care.
Whoa, that's gonna give me autism.
Yeah. Exactly.
Some girl on Facebook told me that.
It's gonna make your ear fall off too. But yeah, no, the thing for me is just do what you can. And, you know, if it's going to be a pandemic, worrying about it has no impact on it. So, you know, if it's that big, we'll deal with it when it comes.
Absolutely. Let's jump into the podcast and solving healthcare, because I think that's an important topic in a lot of different areas, and it's a big topic. Mm-hmm. Because I'm sure everybody with their own related experience has a different opinion on it, right? If I go to the hospital with cancer-related things, I'm going to have an opinion about that. People have their opinions about the mental illness part of it. We talked about it a little off the top, but let's go a little bit deeper. You're publishing these papers. Nothing's being done. Now you have this podcast to get word out and more. Like, what are some of the main things that you're really trying to tackle in this podcast? Like, if you were to pick out like 3-4 themes that you're like, okay, these are like some big inefficiencies, I think that can be managed, or in my opinion would really help fix the system. Mm-hmm. Like, what would those types of things be?
Yeah, I love the question because it's not an easy one, but I'm gonna come from my bias, like my world.
Absolutely.
Okay? One of the crazy amount of resources goes into intensive care unit. So our patients take up about 1% of the gross domestic product. Okay, and a lot of the patients that come through do not benefit from an intensive care admission, i.e., if your grandma comes in and to the intensive care unit and she tells me my goal is to get back home and to be functional, a lot of times that's not possible. Or sometimes even to live independently in general, or even to ever leave the ICU. That is my goal. Often that is not attainable. And quite often we know it as clinicians, but yet we'll still bring in patients that won't benefit from ICU care. So I'll give an example. Obviously this is, what do you call it?
Hypothetical situation, scenario.
But a common one. 95-year-old woman from a nursing home who's demented, doesn't recognize her family, can't eat on her own, has documented that she would not want to be even transferred out of the nursing home for care. You know, if she was sick, just palliate me and allow me to die peacefully in the nursing home. She's found to be, have decreased level of consciousness. You'll get somebody on the phone to the family panicking, saying, "Oh, we need to transfer her to the emerge. She's not breathing well. She's unconscious." Family feels pressure to bring the patient into hospital. They go to hospital. They get intubated and put a breathing tube in. All these procedures, poked and prodded to just try and maintain her life. At $3,000 a day minimum in the intensive care unit for care that she doesn't even want. And if we were to have better conversations with our patients, with our loved ones, saying, what would you really want near the end of your life? This would save the system millions. Like, we're about to publish a study where there was about 12 patients at the Ottawa hospital whose that were taken to the consent capacity board. So what that means is the patient has expressed wishes that they don't want aggressive care, but the families insisted that they get aggressive care. So care that they don't want.
Right.
So we end up going to a tribunal and saying, making our case, and these are 12 patients that have gone through that process. Those 12 patients that we're about to publish cost the system $8 million. 12 patients.
Just 12.
Because their length of stay, I forget, is about 3 to 4 months on average in the hospital. They're in the most expensive area in the hospital, and if I'm not, and actually all of them end up passing away, and so they're receiving care that, once again, they don't even want, and it's costing the system millions. This is a problem. It's just literally burning money, and it's not. And I don't want to come across insensitive to say it's all about the money. They're suffering. They're going through all these procedures, even something as routinely as suctioning somebody through their breathing tube, where you feel like you're suffocating at least 3 or 4 times a day, being poked by, to get blood work on a regular basis, not even to be able to scratch your nose because you're tied down, being extremely thirsty and not being able to do anything about it. They're going through all this because of our lack of communication and our lack of addressing these higher level issues. It's crazy. And in the same time, we aren't funding necessarily all the social workers that would be so valuable in an intensive care unit, physiotherapists that could help get the patient out of bed and get them stronger, stuff that patients actually care about. Mm-hmm. It's not happening. And so this is maybe I should have started off this way. This is what drove my whole research program, is when I experienced, I think I was still training. I saw this patient where he got into a car accident and ended up with a tracheostomy and was really reliant on physiotherapy to help out his lungs. And we were doing such great work. And we were at an era where more and more healthcare cuts were happening. And so going to a long weekend, physiotherapy is not available on the weekend. He gets a pneumonia and plugs off his lungs. Now needs to go back in the intensive care unit, needs to be back on a ventilator. And he's 3-week setback because of healthcare cuts. These short-term solutions that create more long-term problems. And this is insane. This is absolutely insane. We got to do better. We got to figure out how to address this. Mm-hmm. So that's what started the research program. That's what, my first, even one of the main themes in our first few episodes is futile care and the impact it has on society, the patient, the caregivers. The other thing that we don't talk about enough is the impact on the healthcare professionals. Like taking care of someone where, like I'll give this story, Margot, if you're listening, forgive me for saying this story again, but I was training still, and we were taking care of a patient that was elderly and that was dying, but family still wanted us to keep going. And I saw her; she was crying right beside me, and I'm like, Margot, like what's going on? And she's like, every time I walk in that room, I feel like I'm torturing that man. It's awful. I can't do this. And these are the people that are providing amazing care, that are in this game to try and make patients better and to alleviate suffering. And we're not putting them in position to do that. Mm-hmm. There's so many layers there from like the impact of what we're doing. And so that was a huge driver for the show, the research program. And I mean, if you ask me one thing that would make a huge difference, better communication, talking about end of life earlier, more palliative care involvement earlier on. I think these things could have a massive impact on healthcare. Mm-hmm. Plus the 90 other things that we talk about on the show. But like, if you ask me to put a finger on some shit, like that's my huckleberry.
Yeah,
right
I remember my mom always saying, as I mentioned before, my mom's a nurse, and she always said, you ask her, any of her friends of nurses, that when it's our time to go, do not put us on life support. And never really got into details why, but this is like, it would seem they see all this, they do all this, and they're like, fuck that. I don't want that done to me.
Yeah.
Like if it's my time to go, I want to go peacefully. I don't want a tube in my throat and sitting there suffering for like the last days of my life.
Exactly. And like, to be honest with you, just to the listener, what we're saying is, or what I'm saying is, if you're going to benefit from all that, that's awesome. Like, of course, go through it, like, but there's often times where it's clear to the clinicians, they're voicing it. It's clear to the patient. It's clear to even yourselves if you ask the question. But it comes down to like either, I don't know, sometimes it's guilt. Sometimes it's on us too, the clinicians, because we don't want to address, we don't want to address it. Like, I'll give you an example too. Like, there are times where I will go on a ward, see a patient on the ward that has like a late stage cancer, stage 4 pancreatic cancer, for example. And I'll be the first one to tell them that they have a terminal illness. Like their oncologist hadn't brought this up, or maybe if they did bring it up, it hadn't registered. But quite often, it can come to a shock to the patient or the family, and that's like shame on us, man. Like there's like clinicians are often worried about ruining a relationship by being too pessimistic or whatever.
Right.
But the problem is, if you're not being accurate or you're not being absolutely forthcoming, maybe that daughter in Australia, they might never see that daughter in Australia now. You know what I mean? Because they thought they still had months or years to live. Instead of having that awesome connection where that daughter from Australia comes in and they get to talk about good times and maybe spend more time with each other than they were planning on. And so like you're taking something away by not being upfront in terms of the prognosis and stuff. And so, it's a huge problem. And but once again, Ryan, if I had to fix one thing, it would be around that issue.
Right. What's like feedback been for you on the inside? Right. So you're talking about things and people's jobs and how they do things and, talking about inefficiencies from people up top and how it gets filtered down. Have you had any maybe resistance to what you're trying to do? Has it mostly been everyone's like, yeah, like nailed it, excellent. Mm-hmm. Yeah, we need to fit. Like, what's the reception been like from people in the healthcare system?
Yeah, and I don't know. I'm trying to say this without sounding how do I word this? It has been overwhelming, the feedback. It's been something that has driven me to want to do the show more. People have been extremely appreciative and responsive and saying, like, you know, thank you for being, like the nurse episode I did on fetal care. I would get letters, I would get texts saying thank you for seeing us, for recognizing some of the problems that we see. And I got to tell you, it has made it all the worthwhile. And so overall, generally, it's been really positive. My research area in general being cost, a lot of people have, you could see a mixed reaction. Like, people will often say, like, why do you care so much about money? Like, it's healthcare, we shouldn't care. Excuse me. But I want us to be able to fund the things that matter, you know, that matter to us all, you know, and I think if we don't talk about it, then we won't address it. So if there's been any kind of like negativity, it's the fact that I talk about cost as much as I do. But, you know, I think it's ignorant not to address it. And I also think to create change, like the upper management, that's the language they understand, right?
Absolutely.
If you're trying to start a new program or whatever, and you could show that it saves money, ding, 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 you know what I mean? Improves care and saves money, let's go. You know what I'm saying? But overall, I got to tell you, it's been extremely humbling getting the messages and the positive, interactions, man.
Yeah, because you always wonder when you're you know, maybe criticizing cuts and government, like who's up top being like, you calling me out there, you know?
But it's like it's like you said, like on your show, man. Like, you spend, as a medical trainee, you spend a large number of time not being your authentic self, because you are there trying to, like, you get into med school, you got to please your supervisors to get in the appropriate residency. When you're in residency, you got to please people to try and get into your fellowship. When you get in your fellowship, you got to please people to get your staff job. Once you get your staff job, you're the new kid on the block. You don't want to ruffle feathers, so you're still being that person that you think they want you to be. And so I'm grown ass man now. You know what I mean? With some big shoulders. Like, I don't mind when people are creased at me, as long as I can look at myself in the mirror and say, I did the right thing.
Yeah.
You know what I mean? And I think, exactly. And I think there's not enough of us that are asking ourselves that question. Are we doing the right thing? Can you look, like, I like to, sorry if I'm ranting a bit.
I love it.
Like, I like to act like my kids are in the room and they could see how dad's acting right now. If someone pushed over an old lady in a rocker to get in front of a line, well, how would you behave if your kids are watching? You ain't gonna just go to the side and be like, "Oh man, just ignore. We don't want to cause trouble." I'm like, "No, man, this ain't Scooby-Doo. You gotta front, man. You gotta do what's right." This is what I'm trying to teach my kids. This is what I'm trying to, I think more of us need to do is look at ourselves in the mirror and say, "Are we doing the right thing?" And I mean, that's why I always, like, I don't mind getting heat. It's like another thing it's important to me too, and this might seem a little tangential. Like, when we deal with a lot of end-of-life care issues, when we're approaching a family talking about what we think this is the end, one of the common mistakes trainees do or some docs do is say, "What do you want us to do? Like, what do you want us to do now that I've painted a grim picture?" But when I ask that question, I put the onus on you, saying, like, now I'm making you feel like you're pulling the plug. Well, that's wrong, man. I want you to feel like, if anybody, I want you to blame me. The doctors were the ones that were saying that dad wouldn't want this based on his values. So that at the end of the day, if it's a family with mixed opinions, that they're not mad at each other or have this disjointed relationship as a result. I want them to be, if anything, blame us. You know what I mean? Like, because that way we're maintaining that relationship in the family as best we can. And yeah, someone might be upset at me, but at the end of the day, I'm looking at them in the mirror and saying, I'm doing the right thing for my patient and the family. You know, I have no idea how I got on this rant.
Oh, I'm just sitting here just, hell yeah.
You know, I don't know.
Cheering you on.
I've been asking myself a lot about this lately because, you know, justice is one of the values I find the most important to me, and you know, and I've always wondered why that was, and I think maybe it just comes, you know, I was one of like few black kids in Edmonton, Alberta, and you know the amount of like it's not the South like it, you know what I'm saying, but like the amount of, you know, injustice that you would see or be pushed towards yourself, you couldn't help to have that as a value. Like you know, it was enough. You got tired of being called names. You got tired of being looked at different or people making assumptions about you. So it has always been a big or an important value to me. And I don't know if maybe that's why I feel so strongly about it, but certainly it's a big part of my life is, you know, justice for all.
Yeah. I've talked about that numerous amounts of times on the show with different people, and you know, my opinions have evolved on all that, and as I learn more and talk to more people and hear about that and hear about lived experience and all that. So it's interesting you say that and how you carry what you learned as an adolescent and a teenager and as a young adult into who you are now as a doctor, and how you're taking that lived experience of things you've went through and now using that knowledge and passion to support your patients and the families. Like, I'm just hearing you talk about, I'd rather the whole family basically hate me and blame me so like they're good and the person dies peaceful. I'm like, it's admirable. Like, you know, like a lot of people don't have that strength to deal with that pressure, that, you know, like everyone just wants to be liked. I just want you to like me. I'm the nice doctor, you know, or I'm the nice guy. Yeah. Like, so just to hear that, like, it's such an interesting, like, I can just hear the conviction. Like, you're apologizing for ranting. I always say never apologize for, you know, speaking your truth or talking or sharing that, but like, you could hear it. You could hear that conviction. So it's that. Very inspiring for sure.
I appreciate it.
One of the more interesting things I heard in some of the episodes I was listening to is the difference between treating sickness, like in sickness care, versus kind of taking those preventative measures. I know you were talking about social programs, but you know, it's a big thing why I support Do It for Darren in mental health, because they're an organization that directly helps kids before they reach that crisis point when, you know, in their early adolescence, where, you know, you might think of suicide, right? You're giving them the tools beforehand to hopefully never get to that point. So I took that comparable, but it was interesting to hear you talk about it and how much of a difference it could make. And that, I wrote down the number because I found it truly fascinating, that 13% of our GDP goes to social programs. Denmark is 27%. Yeah. And they spend far less on what we call sickness care. So I would equate that to the care, like when you're actually sick, when you have the cancer, hospital, when you have heart issues, instead of being like, no, let's, you know, expand gym time or, you know, get the kids exercising. And, you know, I found that really interesting that you guys were talking about that as physician. Yeah.
You know, honestly, Ryan, we don't learn about this shit. Like we don't, you know, med school was like started almost 20 years ago. And so maybe things have changed, but as far as I know, the social determinants of health, these things that really can make a difference early, we don't talk about it, and we don't talk about the value of it. And if we thought about even without evidence, if you think about the logic, it is sound. You get your kids moving. You get them less likely to. You get them eating, dealing with obesity and eating well. You get your kids feeling supported. Yes, they're going to avoid maybe having that drug overdose or suicide attempt or complications of obesity and diabetes. And there's more and more studies now that I'm been more paying attention to it. More and more studies that are telling you that this is fact, and this is, to me, the future. Like, we really need to do a better job at dealing with the problem before it's a problem. Look at more preventative medicine. I interviewed yesterday or the day before Kate Mulligan. Shout out Kate Mulligan at U of T. What's up? And she's got this program called social prescribing where the doctor says, you know what? We're going to get you cooking classes.
I've heard of that. Yeah, yeah.
Sexy as fuck, man. And they're showing it works. There's like, if you think about it, you're an elderly widowed patient that's coming in with their diabetes, and your diabetes is getting worse controlled because you just lost your husband. You're eating more. Quite often, patients like that, they will die within months just because like they don't have any support. They're like spiritually, physically, emotionally, they've just been destroyed after the loss of their loved one.
I have a friend's mom going through that right now.
Right?
Lost her husband, and he's like dragging her to try to get her out and doing stuff.
Exactly. And you're going to create a situation where the patient feels supported. They're going to feel a sense of community. They're going to get a sense of belonging by, get some skills like eating better, all these things. And there's not a drug that you need to add to this solution. Like, it makes so much sense. And I told Kate that, we'll help her with her study in any way she wants. But this, to me, is the future and where we need to go. Because these $1 million meds that we're doing for our diabetics, and then we're seeing complications from those medications.
You get those commercials on TV where it's like, ask your doctor. And it's like, here's all the side effects. Like, and you're like, oh my God.
Make your pancreas explode. You know what I'm saying? Like because in my opinion, my general mantra with medicine in general is less is more. Like, when you don't have to add something, don't. But this is the beautiful thing of this social prescribing or increasing the support in the community to be able to make our citizens more functional. To me, it's the future.
Just like, it's, to me, outside of the medical profession with like no skin in the game, totally, outside opinion, just seems like common sense.
Yeah.
You get those, you just look at the hierarchy of needs, right? Like you just fill those. And of course, like, people are going to be healthier and happier. And, you hope to cut out those preventable diseases and issues that sort of eventually start clogging up our system in ways.
Exactly.
Like you were saying about, and getting them into the ICU and spending a bunch of money on them, right? Like if I'm not even one who gets sick that often. Like I don't ever go to the emergency. Like I haven't been in since I broke my arm and when I was like 16. That was like 11 years ago. Like, it's just, you get people just doing kind of what we're biologically that we were doing in early human years before we got so used to this convenience of technology and everything, right? Like it's
talking, being together,
being active,
looking each other in the eye when talking, instead of being like, and staring at our phones or talking to each other on our phones when we're 3 feet away. You know what I'm saying? Yeah.
It's, that's a big reason, like, I do this podcast is for the mental health, because it's super interesting, not only to, have these conversations with you and learn and do all these things, but you know, I've met so many people now for the first time. They walk in through these doors, and I've never met them before. And we just talk, and we're friends. Yeah. And it's like it's almost that easy. You sit with someone for an hour, and you're like, oh, yeah, okay, cool.
You know why? Because everyone's fucking interesting, man. Yeah. If you actually, everyone has something interesting to say. Everyone has an interesting experience. Like, even if you take a step back and try and you're at a dinner party, you see this person that seems dry as fuck, and you're like, I don't really want to be stuck talking to him, but you're like, you're ignoring each other or you're talking. Make it a goal of yours to find out what that interesting thing is. That thing that where they start talking about it, they get that sparkle in their eye, where they start to have that little smile in their face, and they're that much more engaged. And often it's something actually quite interesting. Yeah, you know. And this is like, we're here, man. We're together. We're like, let's connect, man. Yeah.
One of my favorite questions, like if I'm interviewing someone for a job, when I was single, I'd always ask people on dates, it's like, what are you passionate about?
Yeah.
Right? Like, that is the easiest way to get them comfortable. It's one of the first questions I ask.
Yeah.
It's not about the job. It's not about this. It's not about, what are you passionate about? Because immediately they'll be like, I am super passionate about this. And then you just see them get excited and they're comfortable all of a sudden. I love it. And they're just like, it's like, okay, now you're ready to talk, right? There's no reason, you know, we've set up so many, you know, not just with the technology on our phones and social media, but like the boundaries we put on ourselves, where we're just like, no, I don't want to talk to anybody right now. I just want to go through, like, no, you can't talk to me because, you know, I might think you're going to hit on me, or I don't trust you, right? And of course, a lot of those things are valid, absolutely, but we've just lost a lot of that human connection. Like, people will get weirded out because they say hi on the elevator.
Isn't it crazy? Okay, were you raised? You're raised in...
I'm from Carleton Place, so that is...
O-Town area.
Small town, yeah.
But you got small
I'm
town
small
flavor.
Town, yeah.
Yeah, because this was one of the first thing I noticed coming from E-Town. Oiler Nation, what's up? Like, in Edmonton, you walk into an elevator, you say what's up to, like, you say hi to people. Like, you say, how you doing, or whatever. Like, that's common courtesy. Yeah. You know what I mean? When I moved to Ottawa and you throw down and say, hey, how you doing in the elevator? Like, I'm not saying everybody's that way, but it's a little bit more standoffish. You'd be like, who is this guy? Does he have an agenda or something?
Yeah, right?
Yeah, you know what I mean? Where it's just like, to me, it was always like, that's what you do. It's just a courteous way of...
I always kind of read them, but no matter what, if I don't talk to them before I leave the elevator, I say, have a good night, have a good day. I don't find that weird. But people are like so taken
because that's I mean, not to be too like dogmatic, but this is what we're supposed to do, man. Acknowledge someone when you're that close to them.
Absolutely. You know? Yeah, it's weird that it's normal to just sit there and just
pretend not to see each other.
Sit on your phone. Just, no, I completely agree. And one of the things that was interesting, just to like set the thing, not the best segue I've ever done, but we're getting there. Social determinants of health. I heard that in some of the episodes. You said it now. What does that mean?
Okay, so I apologize.
That's okay.
I should have been more. It's like your social circumstances, how that impacts your well-being. So if you are, you know, your ethnicity, how much money you make, your housing, your gender, like things that are socially determined, and how much that can impact your care.
Interesting.
And so, like, if you don't have, if you know that you're poor, essentially, you know you have worse outcomes.
Yeah.
Compared to those that have more money. Like, we even see it at a population level. If you were to study people from X area that has lower average income compared to those with a higher average income, the higher average income patients do better. You know what I mean? Patients that don't have a fixed address, so, you know, either they're moving around a lot or they don't have a home, they do worse than people that have a fixed address. So just to make sure I'm clear on that. So are you talking about, like, just in general in terms of health, those people would be sicker? Okay, so it's not, you know, if we both had cancer,
and I was poor and you were rich, that like it would affect me worse, right? So it's just sort of okay. There's just some gray area there.
Yeah, like
okay.
You can't say necessarily it's causing you to do worse, but it's associated with you doing worse. I might be talking out of my ass now, but you know, like certainly there's an association that we both, you and I, like I'm poor, you got all the cake. We both have early stage cancer. The poor person is more likely to do worse.
Right.
You know, the one that doesn't have a fixed address is likely to do worse. So the whole argument is we should be addressing these issues early, and it could have a significant impact on their overall well-being, overall health. Excuse me.
And this would...
So, like, for example, if we improve, like you gave the Denmark example, if more people had homes, for example, like less people lived out on the streets, you're going to have better healthcare outcomes.
Yeah. So obviously it disproportionately affects, you know, people of color, indigenous populations.
Yeah.
So when we take a look at that overall numbers in the population, we can see that those, you know, oppressed communities are like they do worse. Their health is worse.
Their health is worse.
So when you hear people talk about institutionalized racism and all that stuff, that, you know, these things come into play, and there's actually scientific data that like is supporting this.
Absolutely.
Okay.
Like if you, I mean, I'm gonna get Mike Curlew on the show, but the stuff that he sees up north in like a Iqaluit, and you know, like it really is third world medicine. They're sometimes running out of oxygen. They don't have all the medicines or antibiotics that we might have, and these are Canadian citizens.
Right. Well, not to mention, you know, clean water. That's
exactly.
Still not a thing. I mean, getting a whole other conversation on all that.
Like it's I mean,
so
like, it's crazy.
I have 5 adopted siblings, and they're all Inuit.
Oh wow.
So, you know, before, and I've had this conversation specifically mostly with Carrington, who was on my podcast earlier, but we were talking about some of these issues because, you know, just talked about it, I'm a white kid from a small town. Mm-hmm. Like most of my life, I went to school with one black kid, and that was the kid in town, mm-hmm. right? So it was just never experienced anything other than like what I knew. So anyways, as I've grown older, now you start getting involved with, you know, their families and their communities, and you start hearing stories from, you know, the residential schools and like you're like, when you say third world medicine, like it's true. Like not to mention like just like if you want, you know, they don't have sunlight and you can't even get milk for less than like $35.
Right.
You know, like, and that's just very basic vitamin D.
Is
so when you
Coke is cheaper than some of these milk, you know, it's crazy.
I guess like it's a good segue into this question that I wanted to ask you. It's like, so like we were talking about off air when I was talking about mental health and, you know, how we're going to break the barriers, right? So now we're talking about all these issues. People are learning. We're hearing about all these things. Like as a regular day person, mm-hmm. and just to segue a little bit, I had a conversation with someone I work with, and their wife. His wife is a psychologist, mm-hmm. and I tweeted out basically saying like, excuse me, in that reference to that story about all the kids who are seeking mental health access, the 28,000 kids that need help. I said this is why we need funding, and he's kind of saw it and he's like, it's not quite that simple because who are you funding? Mm-hmm. So like all the intricacies aside of the funding issue, and what I'm trying to get at after this big tangent, we all know about it now. What can regular people like me, like people listening, what can we do? Do we need to like go storm down Doug Ford's office and be like, yo, help us out? You know, like how do we tangibly make things better?
Yeah, that's a tough question.
That's what we do here. We ask the hard-hitting questions here, right?
Let
But
me-
people are going to want to know, like, once we start identifying these problems, and it's one thing to have people like, this is what we need to do.
Yeah.
You know, so,
And it's totally fair. It's totally fair. Like
yeah.
what how do we
and especially as a
make that
regular day
change?
person, you know, who might not be able to affect the change in the hospitals or advocate with studies. Like, I just want better healthcare. Like, how do we go about this collectively to actually see or seek change? You don't even have to give me a concrete answer, but in your opinion.
Yeah, I think if I look at things that have changed and the way that it's happened, one is just increasing the awareness and recognizing it's a problem, and then getting, whether it's, you know, social momentum, whether that's in 2020, that's increasing social media presence, whether it's engaging people that can make a difference, whether it's your politicians or people that have, you know, do philanthropy or whatnot. For me, the biggest step to creating any kind of change is to increasing the awareness and just getting it out there, recognizing it's a problem. So, like I said, I got 3 kids. My wife's a psychologist, okay, an adult psychologist, mind you.
Mm-hmm.
I had no idea the kids' psychology problem was that rampant. I had no idea it costs $3,000 to go get an assessment for your kid if you're worried if they have something like ADHD or something like that. No clue. And I'm married to a psychologist. And mind you, my wife will tell me I'm just an ignorant dog that doesn't listen and all this stuff. So yeah, maybe that's a part of the problem. But honestly, like, I'm relatively close to it, and I had no idea the scale of this, you know. And so I ended up interviewing one of our more popular episodes I did with Dr. Adrienne Matheson. She's a child psychologist. And I mean, if you saw my face, if you were in the room and you saw my face during the interview, I was like, my mouth was open. I'm like, God damn, man, these are our kids and we can't even address this, you know? And so to me, without being, you know, somebody that's created a lot of change or experience with it, the one thing I do know how to do and can see is the impact of just getting the word out. Like, this is a problem that needs addressing. And I got to tell you, one thing from doing the show that I've learned too is that often can trigger a lot. Like, for example, Dr. Matheson's clinic, after doing the show, she had some people approach her to do pro bono work for kids. Like, that wouldn't have happened if we weren't increasing the awareness.
Right.
There's a colleague of mine, Mike Hartwick, was talking to me about how we want to do, hearing the show and wanting to engage kids earlier on to avoid problems. He's asking, colleagues now what we could do to try and create a type of program that could improve the situation with kids. Like, he lives near, I'm going to screw this up, near Britannia, and there was like a shooting. Oh man, I should know the name of the kid. I apologize. There was a shooting, I think, last year, and this neighborhood is not safe, and there's a whole bunch of kids at risk. And he's telling me, like, maybe we could be doing something to help them out. Like, like, nothing tangible's happened yet, but the fact that we're talking about it, I feel like something's, these things, some of these situations are going to improve. Excuse me. So for me, that's the big step, is awareness, and see where it goes from there, to be honest.
Yeah, it sparks something. It's like, is there a way to, like, come up with a foundation where you reach out to psychologists or whatever, and it's like they do it at a discount, but they still get paid, where you, like, can do, like, a mobile kids kind of, like, so you fund it.
Yeah.
And people get the work. They get maybe 30 minutes, and you pay them, like, I don't know, maybe they do it for $50 or whatever, $100 or $75, whatever the price is. But like, but you just do that. So you give people, because I mean, like, don't get me wrong. It's the same thing with doctors, right? You guys put, it's like for psychologists, you put a lot of money, a lot of time, and a lot of yourselves into reaching to where you are. So I have no problem with them being paid, and that whole therapist should do their work for free. There's a little bit of a movement. I'm like, no, like you can't do that. You got to pay them, right? But is there a way to make it more accessible in a real way?
I mean, that's the thing. You start the conversation, and there's a million ways to do it. It's like, yeah, could it be discounted? Could you give a certain amount of your hours for free? Can we approach Ottawa businesses to drum up some money to be able to sponsor it? Do you have a walk once a year to increase awareness? You do a telethon. I don't know if telethons exist anymore.
Yeah, some stations and TV still does.
Like
Chio does, yeah.
Like there is 48 ways that you could do this, but the whole thing is talk. Like you got to know it's a problem first, and then the thing that you and I are doing is motivating some cats, man. Like you not only saying, oh, by the way, a lot of kids aren't seeing psychologists when they need to, but it's like the impact of that. This is kids that could be healthier and decreased anxiety, decreased depression, and we're not addressing it early because of a lack of resources. And I'm like, yo, like for those listening, these are our motherfucking kids, man. If you ain't gonna get amped up about something, I don't know what you do, but these are our kids. This is our future.
Yeah. My favorite saying is, well, that I went through this and I turned out fine.
You didn't. I mean, that's. I mean, I don't need to tell you how horseshit.
I read a great article about that and how humans have that value of. I wish I remember what it was. There was an actual term. I don't know if you know, but it that I did it or I went through it, so you also have to. Yeah, no, right?
It's wicked in medicine. There's a term for it, and
I know I read it.
One of my guests used it too, and I can't remember. But in medicine, it's where we see it, not so much in the mental side of things, but we like when I started, I was doing I could be in hospital seeing patients for 30+ hours.
Yeah,
and now the kids have fixed that problem. Where they're not in the hospital 30-something hours seeing patients when you're not at your finest.
How is that beneficial to anybody?
So they've really fixed things, and that's one thing I got to give props to millennials for is just saying screw this, let's go, let's fix this problem, and not just stand for it. Because I feel like my generation's a bit of do as you're told.
That's the way it is type mentality.
Yeah,
I talk about that a lot too, and I have certain things that bug me about my generation and the generation below me because they disrupt a lot of stuff, and a lot of things can be frustrating for the way you do business or everything. But that's one thing I 100% back is they don't put up with the shit that is truly unfair.
Yeah,
and that it's just they're just no. And you're like, well, do it. They're not afraid to be like, I'll walk.
Yeah.
And a question I wanted to ask you about this, which is perfect. I hear about, again, just on an outside thing, I hear about the doctor shortage that, especially in rural areas and, out there communities. Canada is a vast place with not a lot of urban centers. That it's a lot of an issue to get doctors.
Right.
Is the barrier of entry too difficult? Too hard? Is that what it's kind of pushing people's away from being a doctor? Is it, why do you think there is a shortage?
To be honest with you, a lot has changed. So speaking specifically about the rural scenario, it's been a while since I've been paid attention. So I don't know if that is as desperate times as it used to be, but ironically, there's actually, in a lot of areas, docs that can't find jobs.
Is that right? Okay.
Yeah, in my specialty, the main one being ICU, I worked in Belleville, a.k.a. Bell Vegas. What's
That's
up?
where I went to college.
The truth?
Yeah.
Oh,
Loyalist.
there you go. Noise. I worked in Sault Ste. Marie. There was no jobs as an ICU doc. And a lot of ICU docs listening will be like, yeah, I'm trying to find a job somewhere. There's orthopedic surgeons that are doing their second or third subspecialty training, i.e. in their 8th year of training, that still can't find a job. You could be a cardiac surgeon right now that can't find a job. It's actually crazy. So if anything, often the problem is, there's enough work. Like, for example, you know how there's a lot of people waiting to get their hips done or any kind of these orthopedic procedures, but it's just not funded. We don't have enough operating rooms open. So because they can't find work, they're forced to do extra training on stuff that, to be honest, might not be practical. I got colleagues of mine in ICU that are doing a PhD in some shit. Like, I don't know what you would need a PhD in medicine, like on a day-to-day basis, or I should rephrase that. I don't know what you would need higher than a master's level for most ICU related positions, but they're doing this so that they could buy time and have a more attractive resume. So in a lot of ways, what I see anyway is the opposite. It's just the doctors can't find work.
Interesting. Okay.
It's crazy.
Okay. So would there be a difference between, like, say, the hospital work versus, say, a general family practice, like doctor? Like, yeah. So there's a difference in that. Okay.
Yeah, because I think there's a lot of people that can't find family doctors. What's going on there? Let me think about this. I don't know. Yeah.
But basically, like, you kind of have to choose to be a family doctor. So I'll say all these people trying to be, like you were saying, they having trouble finding work. They couldn't just say, I'll go make a family practice.
No, they would have to. Yeah, those guys would have to do some retraining and stuff.
Okay.
So you start to do more fun. I mean, maybe it's been a while since
something
I've thought
new
about this. So it could be that we're not funding enough family medicine positions. So basically, when you're done medical school, there'll be a certain amount of spots for all the specialties assigned throughout the country. And usually about half of that is usually family medicine or general practice. And maybe the problem is we don't have enough family medicine spots, or people aren't interested in it. It's a very tough job.
Yeah.
That is a very tough, underappreciated, under-supported position. And, when you got a good family doc, those cats are heroes. But it's a tough spot. You got to see a lot of patients in a short period of time. Yeah, it's not an easy job.
Yeah. Well, I can imagine. You got a lot of different things coming in, and you kind of have to make quick calls on things, or just kind of send them off. And yeah, I was never good with any of this stuff. That's why I went into radio. So I could only imagine just like the half of it, right? It's interesting. Before I let you go, I really wanted to get an opinion, because you see a lot of it now with social media and Instagram influencers and YouTubers and media personalities, is the alternative medicines. So I'm not talking necessarily about, I had a naturopath doctor on here, and I'm not saying any of that stuff is wrong. What I'm talking about is like the Gwyneth Paltrows, the people who are going on Instagram being health and wellness coaches, who are, one person put out a video, tips on how to overcome depression. People with no background, they took a $50 course on the internet and are now giving health advice. Mm-hmm. As a doctor, like, one question could be like, are you seeing people coming in with the person on Instagram told me to put a banana up my ass and now it's stuck? You know what I mean? Like, you see funny stuff like that. But people, I don't know if it's a lack of trust in the health system, if it's searching for answers elsewhere. I don't know what it is, but there's definitely a rise in it, and it's become profitable.
Yeah.
Like, I don't know if you have an opinion on that as like a...
Yeah, I have a few things that come to top of my mind. Like, first of all, anything complimentary, I don't care what you're doing. Like, as long as you seriously should be considering therapy that we know is effective and comes with evidence. Like, if we know you got a curable cancer and you need this chemo to take it, please take the chemo. If you want to take this herb that your naturopath gave you and it doesn't interact with the medications that we know are going to work, I have no problem with that in general. I think a lot of it comes down to a lack of trust, and I'm not sure where we lost the trust in the medical community. Like, Dr. Google is way, like, people feel like they have the same voice based on the fact that they Googled it. And, you know, I've got years of expertise on a subject, but, you know, Dr. Google maybe is just as good or maybe even more appropriate. I don't know, you know, like, I think that's been a big part of things. And the other thing, I don't know how to say this without sounding like a arse in a way. We just, people, one of the life skills that we don't emphasize, or, you know, like, in school, you're still learning how to memorize a ton of stuff, right? Our kids coming through, you're going to be able to look up a ton. Like, I was of the generation where, like, you had to go to the library to look up some shit, encyclopedia and all that. But now you got your phone, you got all these kind of, your information's at your disposal. It's easy to find out stuff. But the thing that we need to emphasize and people don't think about well enough is how to critically think, how to actually evaluate the information that's in front of you to say, is this credible? This person that's telling me to put a banana up my ass, what was their background? You know what I mean? Do they have a medical degree? Do they have anything concrete that would give me some security? What is the path? I was going to use two sexy words. What is the logic on why this treatment will work? You got to be able to rationalize that in your head. The banana up your butt, what is the mechanism that is healing my XYZ? Right. There has to be something that you could put, that you could connect, okay? And so this is paramount in an era where you're being inundated with crazy amount of information, or fake news, as Trumpists would throw down. You really need to be able to learn how to decipher what seems more credible and what doesn't, and make a sound decision for you. And this is, I mean, I'm going off on a little bit of a rant here too.
That's totally why I brought it up.
Yeah, I really want my kids, I want the schools. How do we think more critically? How do we recognize what biases are within us or that are being presented to us? Because in 2020 and beyond, this is essential to be able to make wise decisions, period. Yeah. Whether it is bananas or not.
That's true.
Oh, yeah, that was kind of funny. That was unintentional.
Yeah, but it's so true. My favorite saying is just, you know, information is kind of like food in which you can have a bad diet of information, right? And you're right. I referenced it earlier. There's so much to know, and it's coming at you so rapidly. Whether it's what's on the news, what's happening in Iran, Kobe Bryant, you know, China genocide and genocide in the Middle East, and like all that. Not to mention our daily lives, and you know, like, are my kids happy? Am I happy? Is my partner happy? Am I doing a good job at work? People listening to my pod, like, it's just so much
all the time.
And I just, you know, and it's a great point that you have to consciously make an effort to decipher what is good and what's bad. And so many people just don't, and you get lost in this like rapid Twitter sphere of like mentality of mob mentality, and everyone's just the craziest of takes.
Yeah.
Like there's just people I follow on left and right that I see them tweet. I'm like, woo, holy moly! I don't know how you did that and got there, but whoa.
Yeah.
Right? You just are like, damn, man. Like it's hard. It's hard to do, and I can only imagine. Like that's why I laugh because I see some of the stuff like people tried to. What was it? It was it garlic or onions? Like putting it in their vaginas for cleansing or something. And I can only. It always takes me back to the scene in American Pie 2 when he has the crazy glue and it gets stuck. And I'm just like, does that shit actually happen in the ER room? And I remember asking my friend, and they're like, yeah, we've seen some shit.
I don't work in Emerge, but the stories are endless.
I just like, I couldn't imagine. I'm like, no.
Did that actually happen? Yeah. No, it is absolutely bonkers.
Well, listen, man, we could have a 5-hour conversation on all this stuff, but I'm just going to throw them to your podcast because
I appreciate that, man.
I know I fell in love with it, and we'll definitely be listening. So thank you for coming on. I really appreciate it.
Can I give you some love too, man? I really want to give you some mad props on what you're doing, buddy. Like, I want to praise your courage to be able to be a voice for the struggles that many people are having, like having someone that authentically will tell you what they've gone through and to speak to so many people and to reach so many people. I could promise you, without knowing the numbers or whatever, you are having a positive impact on a lot of people's lives. And anybody that's doing that kind of wonderfulness, you got to give mad props to. And
thank you. I appreciate it.
I'm glad I got to meet you.
Yeah, I know we have a podcast meeting coming up soon. And
yes. Yeah, we're going to hash out some I don't know what we're going to do.
Shout out to the interview dudes.
Yo, interview dudes representing hard.
Where can people listen to you? Where can they find your podcast?
Oh, my podcast is everywhere. It's like oxygen. You can see it. It's on iTunes, Stitcher, Spotify, Google Play, YouTube channel. You can follow us at Quadcast on Twitter, Instagram, and Facebook, and on YouTube. And we're just trying to change the boogie. You guys keep checking us out, and we won't disappoint.
Yeah, at Quadcast, Solving Healthcare. And like I said off the top, I'm not just saying it to boost your ego. It was that type of thing that no one is really doing, but it's so vital and tangible to literally everybody. And it's accessible. That's the thing I love about podcasts too. It's free. It's accessible. People can learn about all this stuff, and you're not some influencer just talking shit on Instagram. You got the knowledge, and you have amazing guests who know their shit. So I look forward to checking out Kate Mulligan and Matheson and all that stuff. It's gonna be great.
Appreciate it. Thanks, my friend.
All right, Dr. Kwadwo Kyeremanteng.
Woo!
Thank you, sir. Bye, everybody.
You take the red pill, you stay in Wonderland, and I show you how deep the rabbit hole goes.